The actionable mutations are found in roughly 20 to 25% of our non-squamous population, and probably only in about 2 to 4% of our squamous population. And they go above and beyond EGFR. EGFR is seen in 10 to 15%, although it's much higher in never smokers and women, particularly those of East Asian ethnicity. If you look at that population, it's closer to 50, 60, even 70% adenocarcinoma. ALK is typically seen as well in never smokers in about 3 to 6%. Doesn't seem to have a relationship to gender. Generally much younger patients. ROS1 is similar. Those are the molecular aberrations that are typically seen in the non-smoker subset. But we see a number of actionable mutations in the broader population, including former or even current heavy smokers, and that includes BRAF, it includes c-MET, and several others. And these are also actionable. BRAF, we have an approved combination, dabrafenib and trametinib, that generates response rates in the 60 to 70% range, median progression-free survival of 8 to 10 months. It's quite amazing. That population I would give TKIs preferentially frontline. For c-MET, for RET, for HER2, the data are still a bit murky. I would want to know the status. That can be tested individually. It's much easier to do it in the context of next-generation sequencing. Those folks are probably still best served by chemotherapy or chemotherapy with immunotherapy frontline, with targeted therapy reserved for the second-line setting.
For patients that have mutations other than the known and targetable EGFR, ALK, ROS1, and BRAF, we certainly lack information on how immunotherapy in combination with chemotherapy or combination immunotherapy will work in the frontline setting. As we are treating these patients in clinical trials, we can collect that information so that we can derive useful conclusions about how to treat those patients.
So for patients with molecularly driven tumors, now the top ones like EGFR, ALK, ROS1s, and I think they have a lot of good options for oral tyrosine kinase inhibitors, and they're under intense investigation. But then there are other smaller subset of patients who have a defined molecular marker that now have available options. For instance, patients with BRAF or patients with MET or RET and other type mutations. I would say that as long as there are specific targeted therapies for these patients, I mean, my preference would be to at least get a patient on a clinical trial where these targeted drugs are tested in the appropriate setting. So if I have a patient with a RET mutation or alteration, my preference would be to offer that patient something directly against the RET. There's a lot of confusion or problems with offering IO or treating patients with different molecular subtypes with an immuno-oncology drug simply because we don't have the full information. We know from second-line studies and some of the third-line studies that single-agent IO in specific subsets like EGFR and ALK patients might not be a good idea as an all-comer type of an approach. There is data that, for instance, patients with MET alterations might not benefit from an immuno-oncology drug. But the data set in these subsets are smaller because we're dealing with smaller patient subsets to start with. So I think this is a patient population that if we have exhausted targeted therapies, we actually need to investigate the clinical activity of IO combinations or IO as a single agents in a nice formalized way as part of a clinical trial, and that's the way I tend to look at them. So if patients are appropriate for specific trials, that's what I would like to do.